Hello and welcome to sMater, a podcast by clinicians for clinicians, brought to you by sMater, an Australian leader in healthcare for more than a century. My name is Glenn Minturn and I'm excited to join you as we meet some of our clinicians and deep dive into specialty areas from across sMater's facilities in Townsville and Mackay. Today, I'm coming to you from Kutharinga, the land on which this podcast is recorded, and I'm joined by Dr. Scott Whiting, General and Bariatric Surgeon at sMater Private Hospital, Townsville. Dr. Whiting first completed a Bachelor of Sport and Exercise Science at James Cook University while playing first grade rugby league for the North Queensland Cowboys, before completing medical school at the University of Notre Dame in Fremantle. Dr. Whiting completed most of his surgical training in North Queensland before completing dedicated fellowships in bariatric and upper GI surgery in Auckland, New Zealand and the United Kingdom. Today, Dr. Whiting is joining us to talk about the decision-making process around weight loss treatments. We're looking forward to this one.
sMater.
Caring for the community for more than a century.
Innovators in health, education and research.
Home to world-class clinicians.
State-of-the-art facilities.
High-quality, patient-centred care.
Australia's largest and leading maternity provider.
Turning scientific discoveries into
Educating the
life-changing
nurses,
outcomes.
leading healthcare advancement.
Driving
We are sMater. We are sMater.
We are sMater.
This is sMater.
Scott, welcome to sMater.
Thank you very much. Delighted to be here.
Good to have you with us. All right, to start, give me a bit of background into where your interest came from for bariatric and upper gastrointestinal surgery. I mean, it's not something that jumps out for everyone. Where did you find your interest?
I guess two main areas. My grandfather many years ago passed away of esophageal cancer, and he was probably suitable for an operation, but they didn't offer that type of operation here in Townsville at the time, and they said, well, he needed to go to Brisbane. Much of a different environment back then, and he wasn't prepared to go to Brisbane. So I guess growing up and experiencing his journey through dealing with that cancer obviously directed me towards, I guess, upper esophageal, gastric, and those what they call upper GI surgery. In regards to the bariatrics, I did a sport and exercise science degree at JCU, and so I've always been interested in that lifestyle and health and fitness. And when I came back to Townsville and worked as an intern, as a surgeon by the name of Dr. Sam Baker that was doing the bariatric and the metabolic surgery at the time, and I had a really good experience working with him, and things just went from there. So it became a nice partnership between what I'd done previously in my degree with sport and exercise science and then now this metabolic and weight loss surgery.
Let's talk about how far progressed can gastric and esophageal cancers be for you still to be able to effectively remove them with minimally invasive surgery? Yeah,
this is a really important topic. When it comes to esophageal and gastric cancers, or even any cancers of the upper GI tract, which include pancreatic cancers and liver cancers, they really have a poor prognosis compared to other cancers that we face as a society, like breast cancer, prostate cancer, and bowel cancer, and they don't really get the appropriate funding. And so we are really working hard on that. The reason why the prognosis is often poor is they present really late. And so by the time you're getting symptoms of these cancers can be very advanced and sometimes to the point where we can't achieve a resection. So for us to be able to achieve an operation in the hope of achieving a cure or long-term control, we need to be able to ensure that there's no evidence of cancer elsewhere in the body, that it hasn't spread to the liver or the lungs. We need to make sure that if it's involving lymph nodes, that those lymph nodes are close to the esophagus or close to the stomach and that are not distant. If we're able to do that, then our patients are often in for quite a tough time. You routinely undergo neoadjuvant chemo or radiotherapy, where we actually try to treat the cancer early, because when you have these advanced cancers, there will be microscopic tumor cells floating around in the blood, and that's where patients get their recurrence, and that's how the cancer comes back. And we need to treat that. We also, hopefully, with that early treatment of chemotherapy, we're able to shrink the tumor down, okay, and we're able to allow us to get better resection margins, All right. Once they've undergone that intense chemotherapy, we then get to the surgery. And as I've explained before, this, even though it's done keyhole, it's still a very invasive procedure. The complications of the operation can be very serious. And then once they recover from that, we put them through another round of chemotherapy. Wow. So this is a very big undertaking, and we do our best, but there's still a lot of work to go when it comes to managing these cancers.
The off-label use of diabetes drug semaglutide, better known by its branded name Ozempic, to help people lose weight has led to a surge in demand and a global shortage. The drug, a weekly injection approved to lower blood sugar in adults with type 2 diabetes, was accessed by 175,000 Australians through the Pharmaceutical Benefits Scheme in 2022. The annual number of users had already jumped to more than 268,000 by the start of November 2023, according to the ABC, in part due to widespread discussion of the drug's effects on social media.
Scott, there's a lot of different treatment pathways for weight loss. Can you talk us through occasions where drugs may prove effective in this area?
Yeah, absolutely. I think when it comes to understanding obesity and the effect that it has on society, we need to understand that it is a chronic condition, okay? It's often relapsing, all right, and it can be progressive. So we need tools to be able to help us on that journey. Part of the tools include these weight loss medications. They can include other things like intragastric balloons and also surgery. For the patients, I think we're medications, and they have been around for quite some time in various forms, and we will continue to develop further medications that target different areas. But the patients that I think generally do best are those early in their journey. If they've reached a BMI of over 35 or particularly over 40, then we're not really going to achieve the weight loss that we're hoping for purely with medications.
So where the drugs may not be the best option then, what are the sort of factors that determine whether medication or surgical procedures would have a better outcome for our patients?
Yeah, it's a good question. When it comes to, I guess, what we would say the health-related conditions that are associated with obesity, and what is the best way to treat those. And we know for patients that may be struggling with obesity, but also diabetes, we know that surgery is very powerful. And in fact, some of the operations that we perform can put the patient's diabetes in remission the moment the surgery is completed. All right.
Yep.
When it comes to the medications, we need all of our patients to have a very good understanding of what's involved in surgery, and also attempting some lifestyle and modifications. And sometimes that includes using medications to help assist them on their journey. So that's very important as well.
What about age? What sort of factor does age have in determining what the treatment's going to be in this particular area?
Yeah, that's a good point. The American Obesity Association, or the ASMBS, just released a guideline on that very recently, and it goes to the age-old saying: "Is age just a number?" And on their review of all their cases and all their data, it was just a number.
Wow.
And so age itself shouldn't be included in making a decision. It's about the patient's overall health. And we use this term frailty, and we get a little bit frail as we get older, and that's usually an accumulation of a number of medical conditions. And providing the patient is very well, it is healthy, doesn't have too many of these medical conditions, then age is just a number, and we can safely treat patients well into their 70s.
The Australian Family Physician Journal identified a clear net benefit for properly selected patients with clinically severe obesity in terms of improved health outcomes and reduced mortality following bariatric metabolic surgeries. However, only when paired with post-operative follow-up and adherence to recommended lifestyle changes. The article recognised the crucial role general practitioners play in the management of obesity through not only providing referral pathways for treatment, but the long-term multidisciplinary support and monitoring post-procedure.
Scott, when we do take a look at bariatric surgeries in particular, what are the sort of main factors that influence a patient's decision between different treatments, and what would be the benefits of a band over a sleeve or vice versa?
Yes. Essentially, I think any patient looking at undertaking weight loss surgery, they need to be prepared, they need to be educated, and they need to be committed. Okay, as I said, obesity is a chronic and it's a lifelong condition, and it's just not something one intervention or one medication will fix. When it comes to deciding on the choice of operations, there are a number of different operations that are available. There are 3 that are routinely done in Australia, and there's another 4th operation that is becoming increasing in popularity. The most common operation that's done is a procedure called a sleeve gastrectomy. That represents about 80% of all weight loss operations done in the country. All right. It is a very effective operation, and it's very safe. The safety profile for a sleeve gastrectomy is excellent. All right. This operation is great for patients that have limited medical, what we would call comorbidities. It's great for a young patient as well. It's really good for patients that have problems with their volume control when it comes to eating. Mm-hmm. It can take their hunger away and really restricts just how much they can eat. It is also a flexible operation that if further operations need to be done down the track, it can be built on. It can be converted to a Roux-en-Y gastric bypass, a mini gastric bypass, or even one of these new SADI procedures. Other options, including these bypass operations, where we not only restrict how much patients are able to eat, but we also bypass lengths of the what we call the small bowel. And the small bowel is where we absorb our nutrients, and we talk about macronutrients. That's our carbohydrates, our proteins, our fats, and we also talk about micronutrients. So we're not absorbing any of those nutrients as efficiently. So from the point of view of weight loss, it's great because we're not getting those excess calories that we might be getting from eating too many carbohydrates or fats, but we also have to be careful because may not be achieving our micronutrients as well. So between the combination of restriction and malabsorption, we can achieve some very good weight loss outcomes. Patients that would do better from these bypass type of operations, essentially those patients with diabetes, they do, whereas as I mentioned before, there's some excellent studies that have been done not only within Australia, within Australasia area, but also in Europe, where patients can get long-term remission from their diabetes from these operations and almost immediately post-surgery. Patients with reflux, the sleeve gastrectomy can sometimes contribute to some reflux type symptoms, and a Roux-en-Y gastric bypass is an excellent anti-reflux operation. So for those patients looking to lose weight with reflux, the Roux-en-Y gastric bypass is probably the option of choice. For those patients that have a few medical comorbidities but no reflux and we're looking for a little bit more longer term a weight loss, or a little bit in the older age category, then an operation called the mini gastric bypass is becoming more and more popular.
So many of these are about commitment,
yes,
not just a magic solution. So what sort of long-term changes are these patients needing to make, and what should GPs be looking for in checkups down the track?
Yeah, that's a good question. So leading back to what I've said, patients need to be very well educated and around the procedure itself, what it is that they were trying to achieve and how to work with it. After all, surgery is only a tool that assists a patient in their weight loss journey, and patients need to be able to know how to use the tool effectively. And that provided education, not just with dietitian support in about choosing what to eat and how to eat, but we also need to understand why people are eating as well. And surgery won't fix that. So close attention to the psychology behind eating is very, very important. And that is probably an area we need to improve on as a whole moving forward. For following up patients that have had weight loss surgery, from a general practitioner perspective, we expect most of our patients to do very well, regardless of how they're tracking psychologically in the first 12 to 18 months. The restriction that the surgery provides is usually enough to, overcome any non-compliance, I guess, with lifestyle and dietary modifications. After that, the patient's metabolism will slow down. They'll be a little bit more compliant in how much they can eat. So they can be at risk of weight regain, particularly if they're not following up closely or paying really close attention to their dietary and lifestyle factors. As stated before, these bypass operations are becoming more common. And so looking at micronutrient deficiencies is very, very important. If patients aren't taking multivitamins, if they're not and there are quite a number of very specific bariatric multivitamins on the market, which they should be looking at. Then these patients can present with a range of uncommon symptoms that can sometimes be a bit confusing. So from my perspective, any patient that presents that's had weight loss surgery, we usually start with a full nutritional screen. All right, and I've been to a number of the GP practices, and we've sent out our normal blood tests. They look like they're huge, and I wonder why we get them, but this is the reason. Once we've done the nutritional screen, we then make sure that they are taking their multivitamins, and then we start from there.
Data from the Australian Institute of Health and Welfare reveals 2 in 3 adults, or 12.5 million people, are overweight or obese in Australia, with 12% of Australians living with severe obesity, defined as having a BMI of 35 or higher.
So, Scott, looking at the increasing rates of severe obesity across Australia, what hesitations do you believe there are in undergoing the bariatric procedures?
Yes, good question. So, look, the obesity rates in Australia are, as they are across the world, particularly in the Western Hemisphere, are increasing. And with those increasing obesity rate comes increasing what we say comorbidities that we're going to have to deal with lifelong. Of those, as mentioned previously, diabetes, because of its wide-ranging effects, really can will really impact our society moving forward if we don't manage this epidemic well. Reservations moving forward, we need to make sure that our patients are really prepared, all right, and we're able to provide a good service and good supports for these patients moving forward, because it is a lifelong commitment to them. So when you're undertaking or any program that undertakes weight loss surgery should be making that commitment with the patient. They're going to support them lifelong. The reason why it's important is that when it comes to surgery, our first surgery is our best option. Okay, there's a number of tools that we have in our toolbox, and that include the surgery and medication and specific diets. But the first surgery, that's our best card. Okay, and once we've played that card, we need to support the patient through that journey for as best as we can. There's an old saying that the sleeve that you see never regains weight or doesn't have problems, and so, but that's on us too. Because it can be difficult with life in general to find the time to keep coming back and attending appointments, but we need to offer something for the patients that when they come back. So there needs to be value in that follow-up. They need to feel like they're getting really good dietary advice. They really feel like their medical conditions are being well managed. We do that in conjunction with the GPs. And so that's the reason why we invest in body composition analysis to track our patients. We invest in nurse practitioners and psychologists to really keep patients on track during their whole journey.
And now, before we wrap up our session with Scott, I'm excited to introduce our little segment we like to call the Checkup. All right, well, Scott, we know a little bit more about you as a medical practitioner now, but now we want to find out a little bit more about you as a person, and that means our quick fire questions. Okay. 5 randomly selected questions we're going to throw at you. Are you ready to have a go at this?
Absolutely.
All right, let's go. Question number 1. If you weren't a doctor, what would you be?
Ooh, good question. I would have liked to have been a better footy player.
You did all right for a footy player.
I did okay. Some people say I should have been a vet. I do like my animals, particularly the dogs, and it usually comes out when I'm letting the dogs inside and my wife really wants to get them out.
That's a great answer. All right, question number 2. What would be your top piece of advice for a medical student?
Take your time, get well trained, and really find the area in medicine that you really love and enjoy. It is a real privilege to be able to support patients through their health journeys, whatever stage that they're on. But take your time and do it well, and you'll get the rewards.
How do you want patients to see you?
Oh, that's a good one. I'd like them to see me first, I guess, as approachable. I like to think that I can communicate and have and chat with people just on an everyday basis. I'd like to see when I see patients and I do undertake an operation, I go, if you're in hospital, then I'm in hospital. And I want them to know that if they make a commitment with me, I make a commitment with them, and we're a team moving forward.
That is a really cool answer. I like that one. How do you unwind or relax?
Well, when I get home and when I do have time, I like to spend time with the kids. I like to just basically take them wherever they like to take them. So we really ensure that we have quality time with the kids. They tend to like Kingpin at the moment, which, is nice and loud.
Do you still go to the footy?
Yeah, we still go to the footy. My son plays as well, so we get down to watch that when we can. We also try and get out of the house as much as we can, bike rides with the kids, but we also live fairly close and get out fishing and do those types of simple things.
Very North Queensland. I love it. And finally, what is your theatre playlist? Do you have one?
No, I don't specifically have a theatre playlist. I leave it up to my anaesthetists, and they can be the DJs, and then I quietly judge their choice of tracks.
Great answer as well. Scott, thank you so much for joining us on sMater today. Much appreciated.
No problems. Thanks very much for your time.
For our listeners at home, in the car, or having a well-deserved break between patients, thank you so much for tuning into this episode. For our next Townsville episode, join me on a very special Ovarian Cancer Awareness Month episode with Mater gynecologist and obstetrician Dr. Sally Aubrey. See you next time on sMater.